Bayesian Analysis, an introduction for radiologists. Welcome. In this lecture, I am going to introduce you to Bayesian thinking so that you develop an intuition for this type of analysis. I will emphasize that this type of thinking is important for providers of information. Let's revisit information and the information problem. What is the information problem? You must have heard of the phrase fog of war. What that means is that information can be signal or noise. There are bits of information here and there. Making sense of the two and discerning between them is the job of the provider of information. In other words, information is imperfect. But let's ask ourselves, why do we seek information in the first place? We seek information in order to act. Let's consider something as simple as knowing the outside temperature. Why do we want to know the outside temperature? Because it leads to some actions. For example, if it is 20 Fahrenheit outside, we change our clothing likewise, versus if it's 50 Fahrenheit. Anytime there is imperfect information, there is a trade-off. Trade-off is a fact of life. Anytime there is scarcity, meaning we can't have everything that we want, we need to sacrifice certain things in order to achieve other things. Imperfect information is simply scarcity of the perfection of information. You've probably heard the phrase time and again, diagnostic medicine is not an exact science. That's really another way of saying there is imperfect information when it comes to diagnosis. And I would say that that is a good thing. It keeps us in business. Imagine if there was a cardiac enzyme that was always positive in patients with acute coronary syndrome and only positive in patients with acute coronary syndrome. That would be great for patients with suspected acute coronary syndrome. They would never be underdiagnosed or overdiagnosed, but that would put someone like me, who reads CAT scans of the heart, out of business. So who came up with Bayes' theorem? It was none other than Reverend Thomas Bayes, a mathematician, philosopher, and theologian. If I were to pick radiology's patron saint, it would be Reverend Bayes. Bayes wrote a now classic essay about inverse probability, known as the Essay Towards Solving a Problem in the Doctrine of Chance. It's freely available on the web, and I highly recommend that you read it. It's fascinating. So what is inverse probability? Inverse probability is simply the probability of an unobserved event. It is when you're computing a probability but you do not have the luxury of a sample size. Inverse probability has given rise to a whole branch in statistics based on Bayes' theorem, known as inferential statistics. Before I explain further Bayes' theorem, let me introduce you to another school of thought when it comes to the logic of chance, which is the frequentist approach. In the frequentist approach, the probability of an event, let's call it PA, is a number of events that occur in a particular sample. The sample allows us to approach the truth. The truth itself consists of a universe of possibilities. So let's break this down with a very simple example. What are the chances of landing a heads in a fair coin toss? Well, we know that there are two possibilities, a heads and a tail. And we can infer this particular probability to a good degree of certainty by doing a trial of coin tosses. The more trials we do, the closer we are, or the closer we are to the truth with a certain degree of certainty. Well, what's the problem with the frequentist approach? Well, often there is no simple universe of possibilities, such as the landing of the heads and tails in a fair coin toss. There is no reliable way of getting to the truth. Often you're dealing with an n of 1, and it's very difficult getting multiple n's of that particular one. And more so, even verifying the truth requires time, and time can be precious, particularly in clinical medicine. And so there is no practical way of using the frequentist approach on a daily decision-making basis. The Bayesian approach can be considered a triad, comprising prior probability, new information, and revision of belief or posterior probability. The key to Bayesian thinking is that we must have a judgment, a belief, or in medical decision-making, clinical context. We cannot be non-judgmental about possibilities. Now, this is a difficult point to appreciate because the advice we're often given is that we must have an open mind. In the Bayesian context, an open mind simply means the willingness to revise belief in the light of new information. It doesn't mean having no belief whatsoever. So let's re-emphasize the triad: prior probability, which we can call belief, judgment, clinical suspicion; new information, such as the information from a diagnostic test; posterior probability, or revision of that particular belief. So what this means is that the probability of an event, PA, is affected by new information or circumstances. We don't get to toss the coin 1,000 times, but we do get to acquire new pieces of information that gets us further towards or further away from our original belief. So what are the components of a Bayesian analysis? As I mentioned, it's prior probability, PA, new information, which we call B. And this is where it gets tricky: conditional probability, the probability of that new information given A. Probability of the new information, and posterior probability, the probability of A given the new information. This is a simplified version of the Bayes equation. The probability of A conditional upon B, conditional upon that new information, is the probability of that new information given A multiplied by the probability of A and divided by the probability of B. Okay, enough of the abstract. Let's get down to a hardcore example. The probability of acute coronary syndrome in a patient given a certain EKG pattern, such as T-wave inversion, depends on the probability of that T-wave inversion given the acute coronary syndrome, meaning of all the people that have acute coronary syndrome, how many actually have that change on the EKG? That's one component. The other component is the probability of the acute coronary syndrome itself. How likely really was it? And thirdly, it depends on the probability of the T-wave changes in a population. that may or may not be related to the acute coronary syndrome. Let's try and make sense of this. Imagine that there is a finding that everybody has. Let's say, for example, it is T-wave inversion. It's not the case, but let's just assume that it is. Now your denominator, PB, rises because everyone has it. And so the probability of A/B is lowered. That piece of new information isn't particularly valuable because it's ubiquitous. So really a piece of information is valuable when it's able to discern between what you're looking for, the acute coronary syndrome, PB/A, without itself being terribly ubiquitous, i.e. a low PB itself. One advantage of Bayesian thinking is that it allows you to gauge when additional information is not going to be particularly useful. In the previous example, I spoke about a finding which, if ubiquitous, loses its power to discern and its value as information. Here's another concept, that of independence. If the probability of an event A given circumstance B is the same as the probability of the event A without that circumstance, A and B are said to be independent. Let me give you an example, an absurd one, to illustrate this concept. If the probability that it will rain in Napa given a heat wave in Mongolia is the same as the probability of rain in Napa without that heat wave, the two events are independent of one another. What this means is that knowing about the weather in Mongolia is not going to be particularly useful in predicting rain in Napa. There are, of course, many ways of defining redundant information. My preferred way is to call information that is redundant information that does not alter the probability of an event that we are interested in being informed about. A particular pitfall in Bayesian thinking is the conflation of conditional probabilities. The probability of an event A given circumstance B is not the same as probability of circumstance B given the event A. Again, I will illustrate this with an absurd example. The probability of carrying an umbrella if raining outside is not the same as the probability that it will rain outside if you carry an umbrella. You can experiment that right now if you wish. This is rather like what Mad Hatter said to Alice in Alice in Wonderland. Why, you might just as well say that I eat what I see is the same as I see what I eat. It is amazing, despite the absurdity that I have illustrated in exposing the fallacy, how easy it is to confuse sensitivity, specificity, and predictive values. More on that in the lecture on diagnostic test characteristics. As I mentioned, a key component of Bayesian thinking is actually coming up with a prior judgment, clinical context, clinical suspicion, prior probability. That is important not only because it's a component of Bayesian thinking, but its magnitude actually drives the value of information. Let's look at the equation once more. The probability of A conditional upon B is equal to the probability of B conditional upon A multiplied by the probability of A divided by the probability of B. So you can see that the probability of A conditional on B is affected by the probability of A, which is also the pre-test probability. And no matter how good the probability of B conditional upon A is, or how high that is, it can be brought down to a very low number simply by the prior probability. This is really just a fancy way of saying something which I think all of you know, which is that a low pretest probability of disease reduces the value of a diagnostic test. So you can see that there is an equation that explains why frivolous imaging is useless for all parties concerned. So all of this comes to an important point, which is that medical decision making is essentially Bayesian analysis. Let me give you an example. Consider a 40-year-old female with chest pain. That's all you know about her, nothing else. Remember, we can't toss coins over here. We have to use information to arrive at the truth. And we're wondering whether or not she has acute coronary syndrome. So there's a baseline probability based on age, gender, race, for all comers in that demographic. And then through history and physical examination, mainly through history, new information is obtained, such as comorbidities, risk factors, and the nature of the pain. Every time we obtain new information from history or physical examination, the probability of acute coronary syndrome conditional upon these pieces of information changes, and we get further away or closer towards the truth that we wish to, or rather we get closer or further away to our particular belief that we had in the beginning in order to get to the truth. So after the history and physical examination, there is a new probability of acute coronary syndrome, and the new information keeps emerging, the EKG and the troponins, for instance, and that revises the probability. And finally, the patient has a cardiac CT, at which point the probability is again revised. So you can see that the clinician is continually updating the post-test probability with emerging information. And therefore you can see from all of this that as radiologists we are really Bayesian generators. Thank you.